Second case.
Good morning, and thanks to Indian Academy of Echocardiography, Kerala chapter, for presenting a case of repeated syncope. This 12-year-old boy presented with repeated episodes of syncope at rest for the last 3 months. No family history, nothing of mark noted in a few episodes, but no aura of post-syncopal weakness. Incontinence of urine or feces and seizure were not reported. BMI was 31.2, BSA 1.2, heart rate 25, BP was 110/70, and a respiratory rate of 40. He was referred by, there was mild cyanosis and clubbing. AVP was 15 centimeter in sitting position with prominent A wave, no significant sound or murmur heard, neurological and other examinations were normal. His ECG showed normal sinus rhythm, rate 90 beats per minute. Pulmonaries were noted along with RSR- pattern in lead V1, prolonged S wave in right precordial leads and marked T wave inversions in lead 3, AVF, and V1 to V4. Epsilon waves are noted in lead V1 and AVR. Later has a specificity of 100% for ARBC. 24-hour Holter record showed frequent ventricular ectopics, 3940 over 99,300 beats recorded. No episode of VFVT recorded, however, multifocal PVCs, couplets, ventricular bigeminy and trigeminy were noted. No symptoms reported during recording. Thoracic echo revealed enlarged right sided chamber with RB base 3.6 and length 6.1, whereas RA diameter were 4.5 and 4.4. Proximal ROE OT was 3.2, enlarged. Pulmonary artery main and branches were of normal caliber, where IVC was dilated 2.3 centimeter. RV free wall was highly echogenic and very thin, approximately 2 millimeter. A PFO with right to left shunt was noted. An apical RV 4-chamber directed view showed a large RV with thin and echogenic free wall, akinetic, especially in basal and mid segment. Entire extent of RV wall visible showed akinesia, dilatation, and thinning. Similar features were noted in subcostal view. A diagnosis of ARVC was made. There was mild TR, pulmonary pressure calculated was 25, FC was 0.6, S-wave 10 centimeter. Strain analysis of RV free wall showed a strain of 10.4. All parameters confirmed severe RV dysfunction. RV diastolic dysfunction was noted. The reduced E-wave height, E over A ratio was 1.25, and SD flow reversal recorded in hepatic vein flow. Due to initial non-availability, a CT scan was done, which demonstrated ARVC features. There was MRI scanning showed severe RV dilatation with discontinuous contractions, small aneurysm formation with myocardial hyperenhancement on gadolinium scan. Dilatation of RV OT was seen. Hyperenhancement was also noted in IVS, infralateral and anterolateral walls of LV, showing its involvement as well. RV end diastolic volume index was 95 milliliter per meter square with stroke volume 18 and EF 15% only. Thus, the diagnosis of ARVC was confirmed. With regard to differential diagnosis, both diseases on top, but in here, RV is parchment-like with no erythema as there is no muscle. But the next two conditions, the ECG did not show the diagnostic feature in the presence of structural abnormalities, rule them out. Pulmonary artery hypertension was not noted. A normal CT scan brain and a normal EG record ruled out the last two possibilities. The diagnosis of arrhythmogenic right ventricular cardiomyopathy with LV involvement was confirmed. Patient was initially put on beta blocker, which did not show response, thus put on amiodarone, which resulted in marked improvement. The plan for ICD's placement was made, but due to age and remote location of the residence of patient, making follow-up difficult, parents were reluctant for the procedure. I thank you for your kind attention. And
with the permission of the chairpersons, I'll just take one moment because he is one of our star presenters, because surprisingly we had a case submission from Pakistan, a very senior person. So on behalf of IAE chapter, Indian Academy of Echocardiography Kerala chapter, we thank Dr. Imran Hamid for being with us today across the borders. So thank you so much. So chairpersons, please.
Can I speak?
It's going to James to thank you on behalf of the chairpersons and IAE. See, the ECG and echo itself is almost confirmatory for diagnosis of ARVD. Isn't it?
Sorry, I cannot understand.
Yeah, even before going to the cardiac MRI, the echo as well as the ECG was very much suggestive of ARVD.
Yeah, that is right. It goes along with the TFC criteria as well. Because previously we used to have ECG and the family history and things like that, the three criteria. A CMR or MRI is a late development. So, but that is a very good entity to diagnose it, short of biopsy.
Actually, I have already suggested a blind blood pool, that is the T1 images, as well as the late already enhancement in the MRI phase. Because that will have, give an idea regarding how much fatty infiltration is there, as well as the scars.
Yeah, gadolinium enhancement shows its scars. So that was noted in LV, in some part of the LV, actually in typical parts of the LV, that the septum and the infralateral wall. That's why I added to the diagnosis, with the diagnosis of ARVC, the LV involvement. So, in RV, it is quite evident.
Yeah, and those the deep images, the blind blood pool images, that would have been more suggestive of how much fatty infiltration is there.
Sorry, I could not get you.
T1, the blind blood pool images
Yeah.
would have been better from the diagnosis, because it gives the idea of the fatty infiltration.
If you note the second image, the four-chamber image, that shows very clearly the dysynchronous contractions, aneurysms.
Agree. The diagnosis is 100% better. There is no doubt.
Yeah.
They are suggesting two more images would have been better.
Yeah. We got more images, but actually because of the limitation of the presentation, I added only 6 of them in the slide. But there were a lot of images for me.
Sir, that this is going as hexational syncope or?
No. The point is that this boy, a 12-year boy, he did not have a syncope. He had syncope at rest most of the time. That's the 2 or 3 pointers which make this case unique. Is that early age of presentation, because ARVC, as you know, it presents in 20s or 30s, one thing. And secondly, the involvement of LV and the presentation, the syncopal presentation at rest. And the fourth thing is that although we could not demonstrate ventricular tachycardia or VF during Holter records, but I think that is responsible for his symptoms, most likely.
Little aggressive. Okay. Shall we move? Thank you.
Can I take just 1 minute? I will like to thank the Kerala chapter and the Indian Academy, because I saw your post on American Society of Echocardiography website. So I was thrilled to join you people so that we can enjoy the echocardiography. And till now, it's very good presentations. All till now we have heard, and we will hear more good presentations soon, inshallah. Thank you very much for joining me.
Thank you, sir.
Please contribute next time also when we have a next session.
Sure,
Thank you.
Dr. Prabha. Sure.
Thank you.